Hello, everyone. Welcome to the second episode of the international edition of the Art of Drug Choice, Wet AMD, and the latest data. We're lucky to have our esteemed colleagues from around the world here today for a very robust discussion. We have Dr. Peter Kertes from University of Toronto, Canada.
Hi, Arshad. Thanks for having me.
We have Dr. Seenu Hariprasad from University of Chicago.
Thank you, Arshad. It's an honor to be part of this wonderful program.
And Dr. Justus Garweg from University of Bern in Switzerland.
Happy to join the discussion.
This is episode 2 of 4. Last time in episode 1, we discussed treatment options, switching therapies, and dosing strategies. Today, we'll discuss phase 3 data and post-approval data, and also review a case with Dr. Kertes. In future episodes, we'll discuss pipeline candidates, and we'll wrap up the series with a discussion of safety. For now, let's get to the latest data that you need to know.
So I'm going to talk a little bit about 3 studies that are relevant to a discussion of real-world and post-hoc understandings of intraocular inflammation rates related to brolucizumab. The post-hoc data from Hawk and Harrier, Komodo Health Study, and the IRIS Registry Study. So in a post-hoc assessment of the phase 3 Hawk and Harrier studies, it was found that the presence of anti-drug antibodies may predict higher rates of intraocular inflammation in Hawk and Harrier. And there's more data that continues to be collected, and I'm sure as time goes on, we'll have more and more information. There are also a couple of important post-marketing database studies on brolucizumab from the Komodo Health group and the IRIS Registry group. The upshot of the Komodo Health study was that a history of intraocular inflammation and retinal vascular occlusion were linked with increased risk of inflammation during brolucizumab therapy, as was female sex. The post-marketing database study on brolucizumab from the IRIS database, the message from that study was that a history of intraocular inflammation or retinal vascular occlusion was also linked with increased risk of inflammation during brolucizumab therapy. In the IRIS registry, there were 12,000 patients enrolled, and it's a database of real-world patients that's maintained by the American Academy of Ophthalmology. The main findings were that the highest observed risk of developing intraocular inflammation or retinal vasculitis or retinal vascular occlusion in the 6 months after the first injection of brolucizumab was a history of intraocular inflammation or retinal vascular occlusion in the preceding 12 months. Of note, there was a 0.46 risk of intraocular inflammation for all eyes treated with brolucizumab, but that risk was nearly 4% or 3.97% for those individuals that had a history of prior intraocular inflammation or retinal vasculitis or retinal vascular occlusion.
Peter, that's an excellent summary for a lot of data you just did, so appreciate that. So quick question for Seenu, based on what Peter just discussed. I mean, does this data impact how you are gonna pick patients for treatment with brolucizumab, prior IOI, female gender? Does that really matter?
Of course it does. I mean, we need to consider all these things when choosing the right patient to switch or begin brolucizumab therapy. So all of the above. The female gender, I'm not so convinced, but it's something I certainly think about. And I just wonder if it's because females have a higher rate of systemic inflammation, who knows? But of course, I take all this into consideration before advising or discussing with my patient whether they should be switched or started on brolucizumab therapy.
I agree with you. So, I don't exclude female gender for sure, but if they have history of obviously IOI and retinal vascular disease, then that's a big question. Just as you have been using brolucizumab for past year or two already, how are you screening your patients for history of IOI and retinal vascular occlusion?
What I think is definitely an issue is intraocular inflammation at any point. Vascular occlusion, having passed years ago, may not be that much of a risk factor, I do think, but I would be very careful. The most important thing is not to take a close history, because you will hardly be able to differentiate intraocular inflammation from conjunctivitis if you ask patients. The most important for me is the patient education. You can't see the patient as frequently as to exclude any intercurrent development of intraocular inflammation. And therefore, patient education is absolutely key to diagnose early and treat patients, and thereby giving them any chance for a reasonable outcome. And definitely, I would not avoid treating women, because I think women have a greater potential of developing autoimmunity, have a larger, stronger potential of running into more severe inflammation, and are more prevalent in the group of AMD patients, and that may distort the results. So I'm not sure about that signal strength at all.
Yeah, I think the signal strength was, as you said, was not as high as patients with history of intraocular inflammation, retinal vascular occlusion. I think the bottom line is we're still learning a lot. I mean, the drug has been out in the US for past 2 years or so, but we're still learning a lot. And I think this neutralizing antibody data that Peter presented so nicely, we're still learning who are the patients that get neutralizing antibodies, and can we have a test to identify those patients before we start treatment. I think the bottom line is that as physicians, we all want to have a drug that has a good efficacy and safety profile. And if we can decrease the rates of inflammation, if we can decrease the rates of irreversible vision loss with brolucizumab, then of course it becomes a much meaningful option. But even without that test, I think, as you said, Justus, the history and looking into the data that Peter presented in terms of patients, having vascular occlusion or intraocular inflammation, I think it's meaningful to guide clinicians to make better decisions. And of course, we're going to talk about monitoring and safety in the last episode. I think that is also super, super crucial. So great discussions, everyone. I think we're going to move on now. Justus will now present 72-week data for the Archway trial. Our goal here in this episode is to update our audience about the latest data from all the clinical trials that can impact practice.
Thank you, Arshad. In the next couple of minutes, I'm going to present what we know from Archway. Archway is following the ladder trial, which many of you may have heard of, which used an port delivery system with Ranibizumab and showed that the effect of that system lasts for at least 6 months. The Archway trial is going to close results in the next weeks. So we have no published data on that, but we have the interim 72-week data. What we learned is that the port delivery system has to be refilled every 6 months. If it is done so, then the outcome is equivalent to monthly injections of Ranibizumab, which results in a 5 times lower injection rate in the PDS group. In this phase 3 trial, there were 418 patients enrolled, and half of them received the standard dose of Ranibizumab, and half of them the PDS refilled every 6 months. After 36 to 40 weeks, the visual acuity was identical between the groups, and this indicates that there is clearly a longer duration of treatment, and the use of a drug that clinicians are familiar with gives a very high safety level for that drug, because we know what we have to expect and we can predict the response to that treatment. So for our patient in clinical practice, that means a longer duration of treatment and a drug with clinicians are very familiar, but it requires a surgical implantation, which is typically a stress for the patients who have to go to the OR. The need for surgery will probably not change for patients that have a very high treatment demand. The question is whether it is also interesting for patients with this normal treatment demand and a good response to treatment. I do not think that surgery per se is an issue, but we have to discuss the safety, which will be done later. The refilling is critical. You have also to undertake a learning curve for refilling the system, and it has to be done every 6 months, but it could be done in an office setting, which is interesting for the patient. In at the end of the day, I do think that patients will have a significant decline in the number of visits because the 6 months effect of that drug is very reliable with more than 70%.
I think that's a great summary, Justus. I think the question here is, we have excellent data on port delivery system. As you mentioned, the latter trial, the median time to refill was 15.8 months at the end of the study, and you had 80% of patients going 6 months or longer. And in Archway, as you said beautifully, that patients were refilled every 6 months so that everybody is getting treatment. And we continue to learn about port delivery system over time because it's a surgical implant and stays in patients' eyes essentially forever. So we have to talk about safety, which we'll do in the later episode. But question for you, Seenu, based on what Justus has shown, that we have comparable outcomes in terms of visual acuity and anatomy with port delivery system. Obviously, it's placed in the OR. So what kind of patients, Seenu, do you think, if port delivery system is approved, you're going to be considering in your clinic? Are those patients who are getting monthly injections? Are those patients who are getting every 2 to 3 months injections? Because there's a potential that patients may go longer than 6 months. In clinical practice, we do whatever is best for patients. We don't follow 6 months, refill because, trials are done for a different reason for approval. So how do you decide which patients and in your practice to be considered for port delivery system?
This is a tough therapy. I don't see myself using this frequently. I don't think it's first line. I don't think it's second line. It may not even be a third line treatment. And part of the reason is looking at all the other therapies that are in the pipeline between gene therapies, the Kodiak KSI therapy, and with each advancing year, this therapy is becoming less and less relevant. The issue, we're going to talk about side effect profile later, but we're talking about displacement of the implant. Dr. Garweg mentioned that, retinal detachments, vitreous hemorrhage, they're not insignificant, and these are not ultra rare. These are actually quite frequent in the high single digits. And, given the side effect profile and the need that some patients do need boosters, that means I have to bring in everyone for an examination, because you don't know which of the certain percentage of patients that need boosters, you don't know which ones need to be brought in. So that means you have to bring in everyone for an examination to see if they have to be boosted. So even though, yes, some patients got out to several months without needing a booster, you don't know in advance which patients need to be boosted. So, we have to wait and see. This is one of the therapies that we really need to, get in our hands, and in the real world. Obviously the people who conducted this trial are very skilled surgeons and trained and have practice putting these in. But in the real world, let's see what the side effect profile is, and then we'll make a decision about its practicality and utilization in our specialty.
I think that those are a very interesting perspectives. I think it's always good to be conservative and careful, and that's what we have learned from our recent experience with newer agents and technology. Obviously, a surgical procedure, so it is not going to be as safe as injections. I mean, even if we refine the technique, which we have, lowered the rate of vitreous hemorrhage from 50% to 5% in latter with introduction of laser to the pars plana before making the incision. So I'll tell you this, I was also very concerned about the safety, obviously, and long-term impact before I signed up for the ladder and archway trials. And we are in all trials: ladder, archway, portal, pagoda, and pavilion. And I think your point about how you see the benefit until you have experience with it. So obviously the surgical learning curve is there. Initially, it's not a difficult surgery. It's more about learning the little fine details about surgery and making the right incision. If you're not going to make a 3.5 millimeter incision, you're going to make a 3.7 or 8, you may end up with implant dislocation during refill. So I really appreciate that you're honest and conservative by putting patient safety first, obviously. But what I'll tell you is what I was impressed by was patient's preference. So it's interesting, how many patients come to our clinics and they have anxiety and they don't like injections. I mean, as much as we think they like seeing us is okay, but the injection experience, they don't show it. So what I saw was in all my patients where I placed the port delivery system, they were very, very happy. And because they didn't mind coming in monthly for visits in ladder and archway, and then every 2 months, which is in portal, which is a long-term study. But they just were happy. And some of them, or actually almost all of them who had bilateral disease, said, when can I get this in my other eye so I don't have to go through injections? And based on the patient preference from archway, it was almost 93% or so preference for port delivery system versus injection. So I totally agree with you. I think as clinicians, we need to make sure we see the long-term efficacy and safety data. And, safety always comes first. So I think we have to balance, as you said, how this is going to pan out in the real world and the efficacy and safety. And I think risk-benefit profile, as you said, is super crucial for any treatment we have. Peter, any comments to follow up me and Seenu about the port delivery system? And do you feel like there are patients you would consider this for, and your thoughts on the excellent summary that Justus did?
Yeah, I mean, I certainly think that this port delivery system is an interesting device, and I think it's probably one of these things that we'll come back to in the fullness of time for other agents. I mean, certainly Lucentis is an agent that is tried and true, and we know is very safe. But we're supplanting the safety of the drug with the risk of the implantation and the risk, the surgical trauma and the risks of the surgery, which, as Seenu pointed out, are not insignificant. I mean, the patients for whom this is probably most beneficial are those that have a high need for treatment. So although the mean to refill was much higher than 6 months in the trials, I think the patients, who we would favor for a procedure like this will probably need to be refilled, more frequently, maybe every 6 months. And with brolucizumab and even aflibercept and many of the platforms and treatments on the horizon, 6 months is not that impressive for something that has significant risk and involves a surgical procedure. I mean, if this caught on in a big way, macular degeneration is a common problem. It wouldn't leave any time for me in the OR to do things like macular holes. So amongst all the things that we're going to discuss, I think this is perhaps the least promising.
Dr. Kertes made several very important points that I'd like to elaborate on and that I found interesting. The first is when we talk about the patients who will actually get this treatment, the conundrum is that a patient would have to have responded well to anti-VEGF therapy to consider putting in this port delivery system. Why would we put this in a patient who is doing well on anti-VEGF therapy? That it doesn't make sense. So the patients who will actually get this treatment in the real world are, I guess you could call it the bottom of the barrel patients or the more difficult patients. And I think many more patients than we're seeing in the trial will need a booster within that 6-month period. The second is the competition for OR time. I know in my institution, it's we have to work hard to get OR time to do our elective cases and, God forbid, emergent surgical cases. And this adds to the volume of the surgical cases, which can be problematic in certain institutions. But very good comments from the group, and really it's a controversial therapy at best. But I think once we get in the real world, I think that's when we'll really start to make decisions about who this therapy is appropriate for.
Maybe adding to all your comments, one could consider a larger PDS. The thing is drug stability, which is probably limiting the duration and the current recommendation of exchanging the anti-VEGF every 6 months is linked, as far as I have learned, to also in part to drug stability. So maybe you use brolucizumab and you will still not be able to have longer intervals than every 6 months if drug stability is not granted.
I think those are all excellent points. And I think we should not take the surgical training lightly. So as Seenu said, I think surgeons who are in the trial, we went through a lot of training and observation, and that may not be possible. So I think this is going to have a very slow, uptake, because we want to make sure that we don't see complications that we have not seen in the trials. And obviously, all of you know there are things that can change from trials to real world. So I think it's going to have a slow uptake. But, based on my experience, I'll tell you this, is that patients are happy, but of course the safety is different and it's never going to be the same. So I think picking the right patient, if you offer this treatment is the key. And the other question Seenu brought in was the fact that how does this play out with, let's say, faricimab, KSI 301, and then gene therapies, which are one and done in a lot of cases. So I think it's exciting times for us to have options. And other thing Peter and Seenu brought up is OR capacity. I mean, I am doing 10 cases every week. I don't have OR capacity, but I also don't have clinic capacity because you're all seeing a lot of patients. So how do we balance that? And then the practice dynamics from a private practice perspective is also crucial. Like, we have built these large practices that cater to a lot of patients with injections, and you transition those patients out from the injection clinic. Well, how does it impact your staff, your finances, and things like that? So I think there's a lot of discussions about that. So thank you again for robust discussions about the port delivery system. Next, we're going to move on to the Tenaya and Lucerne trials for faricimab. These are the phase 3 trials, and Dr. Hariprasad will give a brief overview of Tenaya and Lucerne.
Thank you, Arshad. I'm sure many of the audience have heard of Tenaya and Lucerne. These are the FDA registration trials for faricimab. As you know, ANG2 is upregulated in pathologic conditions, and it displaces ANG1 on Tie2, leading to vascular destabilization, neovascularization, and sensitization to VEGF-A. Faricimab is a biospecific antibody designed to bind both VEGF-A and ANG2. The trial design is as follows. These are prospective, randomized, double-masked, multi-center studies. And to be included in this trial, patients have to be greater than 50 years old, have vision between 20/32 to 20/320 at baseline. And obviously, the choroidal neovascularization had to be secondary to wet AMD, and only treatment-naive patients were included in the study. And subfoveal choroidal neovascular membrane had to be confirmed on fluorescein angiography or OCT. Patients in the trial were randomly assigned 1-to-1 to faricimab 6 milligrams every 16 weeks after 4 monthly loading doses, or aflibercept 2 milligrams every 8 weeks after 3 monthly loading doses. Each arm had approximately 330 patients, over 90% of whom finished the study at year 1. The primary endpoint was change in vision from baseline, and vision was calculated at the as the mean vision at weeks 40, 44, and 48. So the results were as follows. Faricimab up to every 16 weeks was non-inferior to aflibercept every 8 weeks at week 48. Patients gained on average about 5 or 6 letters in both treatment arms. Faricimab was truly durable by week 48. 45% of patients in the faricimab arm were on Q16-week dosing, and about 80% of patients in the faricimab arms were on every 12-week or longer dosing. The median number of injections in the faricimab arm was 6. In the aflibercept arms, it was about 8 injections was the median. Similar proportions of patients gained at least 15 letters in both treatment arms.
Seenu, great summary here for Tenaya and Lucerne data. I think really exciting to have additional mechanism of action on top of VEGF-A inhibition to see if we can have better durability. And it appears that clearly Tenaya and Lucerne showed us the durability with faricimab. And of course, safety is important. We are going to discuss safety in our last episode, but it appears that safety is comparable. So Seenu, quick question to you. As you nicely presented this data, if faricimab is approved, where does it fit in your treatment algorithm? Is it a first-line agent? Is it a second-line agent for your patients? How do you plan to use it based on the data you just presented?
Oh, I'm certainly excited about faricimab, and I'm very optimistic. The durability is exquisite. Safety is very good. I think there would be many patients where I would consider this as a first-line therapy.
I agree with you. I think for a first-line therapy, we need to have equal or better efficacy, equal or better durability, and comparable safety. And I think here we see that you have better durability than aflibercept. Peter, any thoughts on the data from Tenaya and Lucerne?
The data doesn't blow me away, but I think the structure of the trial was such that it may understate the true durability of faricimab. In real life, we don't, or it's unusual for us to treat patients at regular intervals, except at the beginning. So the capacity of faricimab to extend, hasn't really been tested. And I think once it gets approved and once we have it in our hands, we can get a sense of how durable this therapy really is. I was hoping to see, I know it was a non-inferiority design, but I was hoping to see some separation in the visual outcomes between the faricimab group and the aflibercept group.
We didn't see efficacy improvement or better efficacy with faricimab in the phase 2 trials in neovascular AMD. So we knew that we're not going to see better efficacy in terms of BCVA gains. So that's why the Tenaya Lucerne trial was essentially designed as non-inferiority study, trying to see if we can decrease the treatment burden for patients. And it appears that, of course, the durability is longer. And of course, as you mentioned, in diabetic macular edema, the Ang2 levels are even higher. And in the Yosemite Rhine study, those were also non-inferiority studies, but we saw a significant drying effect of faricimab compared to aflibercept. So anatomically, it was meaningful in terms of drying the retina and getting less fluid. Even in Tenaya and Lucerne, we don't have time to discuss the whole data set, but there was a trend towards better drying with faricimab. So the hope is that, we're going to use this agent, as Seenu said, likely first line to help our patients, and the real world data on efficacy and safety and durability will drive the usage. Justus, any points from you about Tenaya and Lucerne?
Maybe the number of injections is not so much different because of the study design, holding injections in monthly intervals, which is hardly to explain, respecting the duration of effect of faricimab. The thing with extending the intervals is disease activity at the end of year one. It's probably too early to predict the capability of faricimab for an extension protocol, but it's likely that all of these longer acting anti-VEGF drugs, they will less strictly following a treat and extend protocol, maybe by extending treatment intervals by 4-week increments, or by going PRN, because the treatment effect is very much individualized, as we have learned in the early days from brolucizumab treatment naive patients. So there are different aspects. Disease activity at the end of year one is probably gearing the future of treatment strategy in a given patient.
Those are excellent points, Justus. I think anything we can do to push the interval and decrease the visits, and you're right, maybe it means we extend patients not by 2 weeks, but by 4 weeks. So Peter will have to run another study like CAN-TREAT to tell us and guide us with faricimab. So we're going to wait for that. But Seenu, I think the point that I want to discuss or ask you is that given that many of these therapies will extend treatment regimen, whether it's port delivery system, whether it's faricimab, whether it's KSI and other things, what does this mean for practice flow and volume? And does this gives you an opportunity to see more patients, and what does it mean to the business side? For a private practice, I can extend these patients out and see more new patients because we are so full. We can maybe treat dry AMD patients once we have an approval. So, does this affect your practice in terms of practice dynamics, volume, and flow?
That's a great question, Arshad. In academics, we're somewhat removed from the business aspect. We're poor salaried employees, unfortunately, and so it's a little different than private practice. Of course, I'm mocking in some way, but it's not as directly attached to, I see one patient, I make X dollars. Now, but the issue is that this is a good thing. It improves access for our patients. It allows us to maintain some sanity, that we're not just becoming injection clinics, and it allows us to get in those new patients that truly need our surgical retina care. So I think it's a good thing. I think durability is good from the patient perspective. It's good from the caregiver perspective. It's good from our perspective. And from a societal standpoint, it's not just the cost of the drug, it's the cost of the exam, the OCT, the injection procedure. And, with every time you stick a needle in the eye, there's a finite risk that we're taking. So all in all, there may be some hit to the finances, but it'll be more than made up by bringing in new patients that truly need access to our broad-based services besides doing injections.
I think those are great points. I think as physicians, all of us want decreased treatment burden, better visual acuity outcomes for our patients long term, and really, continue to push the space. So I agree with you. I don't think anybody will be mad at having these new agents, because I'm excited for patients. I'm excited for my practice to really extend the patients out, and I'm looking for better outcomes. As we all know, the real world outcomes are terrible after especially first 2 years, where patients lose vision. So again, thank you all for great discussions. For the audience, we are now going to take a short break, and we'll be right back with a case with Dr. Peter Kertes. Welcome back, everyone. Now we're excited to have Dr. Peter Kertes, who's going to be presenting a case for us, and then we're going to have a discussion after his presentation.
Thanks, Arshad. This is a case of a 60-year-old Asian female who came in complaining with a 3-week history of vision loss and distortion in her right eye, and her presenting visual acuity was 20/50. When we look at this en face projection, we could see that there are some polyps and the hint of a branching vascular network. When we look at her structural OCT, she has sort of the typical appearance of polypoidal choroidal vasculopathy. She has multiple pigment epithelial detachments that are sort of thumb-shaped and peaked with some associated subretinal fluid. And when we look at the OCT angiogram, I think it demonstrates quite nicely the branching vascular network, and also the polyps in the deep projections and the RP and choriocapillaris projections. So this is a lady who we actually started on brolucizumab. So she has what seems like obvious polypoidal choroidal vasculopathy. After a single injection, her subretinal fluid disappears completely, and the height of the pigment epithelial detachments is significantly reduced, and her vision improves. So we stretched her out relatively gingerly, and she came back 5 weeks later. Her vision had improved from 20/50 at baseline to 20/32. And again, we have persistently dry retina and a reduced height and volume of her retinal pigment epithelial detachments. So we continued to extend her, and 7 weeks later, she still has stable disease. The pigment epithelial detachments haven't disappeared, but they're certainly smaller than they were at the outset. And at 3 months, or at 12 weeks, her visual acuity has improved to 20/30, but we can see that there's a hint of subretinal fluid that has returned. We know that polypoidal choroidal vasculopathy is associated with high disease activity. It's thought to be a variant of type 1 choroidal neovascularization. Historically, it's been managed with either anti-VEGF monotherapy or in combination with PDT. The PLANET study showed resolution of the polyps in about 40% of patients at 1 year, and about 30% at 2 years. So, and the addition of photodynamic therapy didn't really seem to have much beneficial effect. And it showed that at 1 year and at 2 year, about 20% of patients still had persistent disease activity, even a small number of patients that required rescue photodynamic therapy. And if we look at the Hawk and Harrier studies, we see that the 6 milligram dose of brolucizumab really had quite a beneficial effect on those patients with PCV. There's many fewer patients at 1 year, at week 48, less than 10% of patients had persistent intraretinal fluid and subretinal fluid. And that was really the rationale for starting this patient on brolucizumab.
Thanks, Peter. That was an excellent case. I have a quick question for Justus on management of PCV. Justus, how are you managing your patients with PCV currently, and does brolucizumab fit in as a treatment option for those patients?
Basically, we have managed our PCV cases. As far as diagnosed, we may have had quite some underdiagnosed cases, as everybody has. We managed them with the treat and extend protocol, and the diagnosed cases definitely had a high treatment demand. So I do expect that brolucizumab has its place because it goes better into the depths and it diffuses better into the choroid and also in the vascular complexes. But I have no personal experience with treatment-naive patients, and brolucizumab, the switcher cases, do respond as you would expect if they have a very high treatment demand. To aflibercept, they do respond in terms of a longer interval or better anatomic outcome in terms of completely drying, but with the limited experience we have by now.
Seenu, PEDs always come into play, and of course they are part of the disease, but we don't drive treatment just to treat the PED, but fluid, as we learned back in the day from the Pronto trial. How are you managing your patients with PED and disease activity? A case similar to what Peter showed, and with PCV, do you think aflibercept works better? Do you think brolucizumab works better? Do you have any experience? Because just like Justus said, I think these patients are either underdiagnosed. In Japan, we have a much higher rate of PCV versus in the US. So how are you managing those patients?
I'm certain I'm underdiagnosing PCV in my clinic. The rates in the US are in the low single digits. So, when I'm sure we see them, we treat them exactly like any other wet AMD patient, and they seem to be doing well. I don't recall specifically if I have a brolucizumab patient with PCV. I don't think I do. But I would expect the response to be very good, and you'll see that the case I'll be presenting later on is a patient with a complex subretinal fluid and PED that we switched to brolucizumab, and it's not a naive patient, but the patient did quite well. So in general, and to summarize, I treat PCV just like I do wet AMD with a treat and extend protocol with any of the other therapies.
Thanks, Seenu. From the panel here, any of you, do you use PDT in combination for your patients with PCV?
We have done so in times of Ranibizumab treatment, with aflibercept coming to the market and with increasing experience with aflibercept, we did not use PDT anymore in those cases. Well, there may have been the one rare case which is not controlled, but I don't recall it, at least.
Got it. Peter?
I mean, certainly with ranibizumab and, the publication of the Everest and Everest 2 trials, there seemed to be some advantage to the addition of PDT, but I honestly, I can't remember the last time I did photodynamic therapy for PCV, certainly more than a year.
For the audience, this is a wrap up of this episode. As you know, more episodes are forthcoming. And the first installment of this episode is also available in the podcast feed. Also, please check out images from the case that Dr. Kertes presented on itube.net. Thank you for your attention.